inhibitors of HMG co-reductase, statins, have become first line in our therapeutic approach to correct dyslipidemia in individuals at high and very high cardiovascular risk. There has been the progressive appearance of reports suggesting that the side effects associated with statins in some individuals might outweigh the benefit. Clearly, thoughtful analysis of the whole perspective of benefit risk was needed based on the evidence. And that was the task of the EAS consensus panel, with the initial publication relating to statin-associated muscle symptoms. We did, however, discuss in some detail a number of other low-frequency side effects, of which it was unclear if they were satisfactorily documented clinically and biologically or not. The first one was dysglycemia. Did this really occur with statins, and if so, in whom did it occur and with what frequency? Cognitive function was another major topic for us to assess. In addition, we brought together data for impact of statin on hepatic function, on renal function, any signal regarding hemorrhagic stroke. A further question, is there in fact an increased incidence of cataract in individuals? It was clearly established through our discussions and analysis of the database that there was overall a small but significant increase in the incidence of new onset diabetes, and the rate was very approximately about 1 case per 1,000 individuals treated for 1 year with a statin. So very, very low. And under those circumstances, of course, the rate of decrease of cardiovascular events was substantially higher, an increased risk of a transformation to new onset diabetes in individuals with the risk factor cluster of metabolic syndrome. It's perhaps not surprising, because we need a smaller net increment in fasting blood glucose to pass the threshold for diabetes. Clearly, the benefit-risk ratio with respect to the appearance of new onset diabetes is very, very much in favour of cardiovascular benefit. The panel was satisfied that there was no firm evidence in any report of any trial using a statin for a significant effect on any form of cognitive function. There was, again, no clear evidence for a significant effect on renal or hepatic function. Individuals, for example, with cirrhosis or other severe hepatic diseases were susceptible to a degree of deterioration on statin treatment. This was exceedingly rare. We were absolutely satisfied that there was no evidence in the database for either any increase in the frequency of cataract in statin-treated individuals relative to placebo groups, and the same was true for hemorrhagic stroke. The only exception appears to be the Sparkle trial, in which individuals had previously undergone an ischemic stroke, and there was a small signal in that population on high-dose statin for an increase in the frequency of hemorrhagic stroke. The take-home message for our panel was that overall, across a wide range of patient phenotypes at high and very high risk, that there is no question that the benefit-risk ratio by far favours benefit. I think it's important to point out that very extensive database with many years of patient exposure to statins.